That's very kind of you. I will share my screen. I hope everybody will be able to see the screen now.
We can see that.
Okay, good. So I am Ananda Dhanashekaran. I am a urology consultant as mentioned by Adel. And main other role is I am the BPH lead for our Black Country Alliance Integrated Care Services. So the integrated services actually links predominantly the New Cross Hospital, Dudley Hospitals and Sanville and West Birmingham NHS Trust. Our main aim is to share the learning so that there will be an integrated care, and ultimate aim is to give the best possible care for the patients. In the first of today's discussion, we are going to discuss the GRIFT principles on male LUTS treatment and with a special focus on what the GPs needs to know. So this paper is on towards better care for patients with bladder outlet obstruction. It was released quite recently in January 2022. As you can see from the top, it was well supported by GRIFT, British Association of Day Surgery, British Association of Urological Surgeons, and also British Association of Urological Nursing Team. As you can understand, this is a subject which involves multiple parties and a lot of groups so that we will get the best possible outcome in the male LUTS patients treatment pathway. Historically, the starting point is identifying a quality improvement process. There is a definite suboptimal gap in the male LUTS treatment pathways. And the National Specialty Report for Urology published in 2018 that created a kind of awareness on various subspecialties in urology, including cancer pathways and stones and BPH. We all know that the NICE guidelines gives us the best possible and clearest evidence, but unfortunately for male LUTS, the NICE guidelines dates back to 2010. So obviously there is a place for improvement and place for revision. So the whole idea of the GRIFT service is to define the first class clinical services, how we should function. And as I said, there are a lot of other parties involved like BOWS, BOUND and BATS. GRIFT Academy is started as an objective to create a kind of a library so that we all will have a single point access to various resources so that the patients will get the best care. And we have got an appropriate documents on male LUTS in the GRIFT Academy. So the management of male LUTS is getting more complex because we are getting more amount of surgical options. As far as the medicines are concerned, the options remains almost the same if I'm correct for more than 15 years now. Patients can now be offered various treatment pathways. Monopolar TURP, the so-called gold standard, is slowly losing its plot. All men requiring the prostate surgery should be counseled with a patient-centric approach. Not every man will be suitable for most of the procedures. There are some men who are suitable only for just only one type of intervention. Some of the technologies can be delivered as a daycare surgeries and even in outpatient settings. That created much more awareness on the pathway, and that will further lead us to create much more better quality service. The lower urinary tract symptoms associated with BPH is a very common condition, as you all know. You may be seeing these patients quite frequently in your practice. Over 1/3 of men in UK are living with moderate, if not severe, urinary symptoms, for which the major condition is the bladder outlet obstruction. This equates to a massive 3.4 million men in UK. So you can see the volume of patients who are requiring this procedure. And by creating an appropriate pathway, we will serve a major chunk of our patient population. Lifestyle modifications and medications, as we discussed, are usually the first line recommendations. If you take it date back even to 2010 NICE guidelines has clearly advised GPs to take care of the medications and lifestyle changes. But unfortunately, even after 12 years, we are not performing well in that aspect, and patients are referred to tertiary care without appropriate initial medications prescribing. We have a suite of minimally invasive surgical treatments available, which I will be going through in this presentation. What is the benefit of improving the care in a bladder outlet obstruction patient? We are able to give a patient-centered approach, and we are able to measure the outcomes by using various metrics and like hospital stays, readmission rates, retreatment rates, etc. As I said, we are able to do many procedures as day case or outpatient settings. I think, Adel, there are some microphones
Yeah,
not
sorry,
muted.
yeah.
Somebody
Can
can
everyone
mute. Yeah.
go on mute, please? There's some background noise interference. Can you get everyone on mute settings, please?
Thank you. And these kind of day cases and outpatient setups really reduce the stress on the inpatient beds. It reduces the disruption of cancelling the operations, especially the cancer operations. It frees up the theatre capacity for more complex procedures, and also it optimizes the waiting list management. So we can divert a good handful of men waiting for lower unit tract surgery into the daycare and outpatient setting pathways. This also encourages the urologist to subspecialize in this particular group. If you date back maybe like 10 years back, urologists will be having special interest in, say, prostate cancer, special interest in the upper tract cancer, special interest in female urology, and there is a big general umbrella group by name endourology. But there is no specific special interest on male LUTS. Now, as I said, because of availability of so much of surgical options, now we have this male LUTS getting up into a specific subspecialty. The bladder outlet obstruction pathway ensures that the protocols are available for the primary care colleagues, so that seamless care is provided for men with LUTS right from the primary care itself. Sorry for a very busy slide, but I will really divide it into very, very simple things. So this whole slide is divided into three halves, we can say, with this blue line. So whatever on this left side is the GP remits area, whatever in the middle 1/3 is for the urology services, and whatever on the rightmost is discharge and follow-up, again it's in the GP's area. So patients can present with GP in various methods like acute painful retention, chronic retention, bothersome symptoms, or with some red flag symptoms. If it's acute retention, it is better to be monitored and maintained in the tertiary care. So a patient needs to attend the tertiary care for catheterization, appropriate trial void without catheter, etc. If the patients are in significant pain, if the GP is well, armamentarium is maintained, they can catheterize the patient and refer the patient to tertiary care. Chronic urinary retention or not as urgently needs to be treated like acute retention. So patients can be referred based upon whether they have chronic kidney disease or not. And depending upon the EGFR, they can have catheter or they can go for a catheter independent pathway also. So in today's presentation, we are predominantly discussing on the bothersome LUTS patients. As it is mentioned, you can see this square lies on the GP's area. So GPs should be able to provide lifestyle advice, alpha blockers like tamsulosin, 5-alpha reductase inhibitors like finasteride or dutasteride if PSA is more than 1.4 or for large glands. So this blue arrow specifically addresses how GP can change and improve the patient's treatment in the GP surgery itself. In my practice as a consultant for, as I said, for maybe for 8 to 9 years, most often patients were referred directly when they have symptoms to tertiary care, when these can be addressed at the GP surgery itself. Of course, if there are some red flag signs like, for example, abnormal DRE or increased PSA or hematuria, they will take an entirely different pathway of 2-week cancer rule, which GPs are quite good in doing that. My sincere appreciation to that. Once GPs are able to treat these patients with the primary treatment of lifestyle advices, alpha blockers and 5-alpha reductase inhibitors, the patients can be reviewed in 6 weeks' time, and if they are comfortable, GP can keep the patients themselves and there is no need for any tertiary care referral. But if these measures fails, then patient needs to be referred to tertiary care. where we should have the one-stop assessment, where we have all the subsects like IPSS scoring, examination, flow rate, cystoscopy and prostate volume measurement if necessary, and finally ending up in PDA, which is patient decision aid, which is a very important tool with which we can decide which patients require which type of surgery based upon the size of the prostate, which we'll be discussing further. So the treatment in tertiary care predominantly is helping the patients to get rid of the catheter. They may be heading up towards the surgery, and chronic urinary patients can have surgery or long-term catheter based upon the individual performance status, and based upon the size of the prostate, the surgery can be tailored. And then the patients will be referred back to the GP, where we need a 3 months patient oriented outcome measures, and then the patient will be discharged completely back to the GP. So even though this is a busy slide, the take home is GPs can do a lot of things in their surgery, and patients can be referred only if the primary steps were not successful. I know it's a very big culture change. It won't happen in few months or years. So this needs to be slowly getting practiced, and this will create a lot of improvement in patients' outcome. This will reduce the pressure on the tertiary care, so that the tertiary care can spend time in the patients who really need surgical intervention rather than giving prescriptions and maintaining the medical management. So the important updates in the GRIFT is the ongoing catheterization needed. The patient should have an absolute indication for surgical treatment, and clean intermittent self-catheterization should also be considered. A lot of patients who have good andrexicity, they can do clean intermittent self-catheterization rather than having a continuous bladder drainage. We all know that continuous bladder drainage will result in low bladder capacity, and left in long term, it can cause significant iatrogenic complications. Catheterized patients and those who are doing clean intermittent self-catheterization should be prioritized either for medical management or catheter management or surgical management. We are developing functioning urology area networks. We are discussing the Black Country Alliance, which is one of the urology area networks, which result in amalgamation of various services. We need to avoid patients waiting for surgery to a maximum of 3 months as per the GRIFT metric, which is now absolutely out of our control. Discharge and follow-up and appropriate guidance to the GPs. So tertiary care, when they refer the patient back to the GP, there should be a clear-cut guidance of what needs to be done, and if it fails, what is the plan B, and if it fails, when the patient needs to be referred back to the tertiary care. Patient initiated follow-up, this is something which is coming up in orthopedics, in cataracts, in various specialties, where patients are discharged with the confidence that they can initiate a follow-up back into tertiary care independent of the GP. Because the last question the patient asks me when I'm referring them back to the GP is, "Oh doctor, it's quite difficult to see my GP." And so if I give them a kind of patient initiated follow-up package, patients are empowered to come back to us directly. That reduces the work pressure of the GP surgeries. So if you see, it works hand in hand. By taking away the lifestyle changes and medications to the GP surgeries, we are relieving the pressure on the tertiary care. By giving this patient initiated follow-up when the tertiary care discharges the patient, it releases the pressure on the primary care. So it works quite like a hand in a glove, they say, so that the overall patient care is improved without having any stress on both the systems. One-stop LUTS clinic, as I said, in the second half, we will be discussing this quite in detail. We have spent a lot of time in setting this up, and it's still in a very ongoing improvement stage. This is a very ideal forum to assess and also plan the treatment for patients' urinary symptoms. It streamlines the clinical assessment so that in one place, patient will have all the assessment tools available, and patients are adequately supported with various materials, leaflets. As I said, the patient decision aid is available on the spot. It is necessary for the patient to refer to another hospital in case if that particular type of surgery is available in another hospital. There is no need for us to refer back to the GP to say that this service is not available here. Could you please refer this patient to, say, for example, New Cross Hospital? So the tertiary care can do themselves, which will reduce the patient pathway, which will also reduce the work burden in the primary care. So key decision making tool, discussion on the presentations, patient outcomes, involvement of urology nurses, all these can happen in the one-stop LUTS clinic. Managing patients in the timely manner, this is the main crux of the whole thing of reducing the pathway times, reducing the patient visits into single visit rather than the multiple visit. So we need to ensure that the men with severe symptoms are prioritized. So only way by which we can do that is the GPs needs to do the IPSS scoring system, which is a very simple tool which all nicely in the training module. I know the GPs, surgeries, trainees who are attending the clinics with me, they know about the IPSS scoring. But once they reach into a full-fledged practicing GP, those kind of scoring system practices slowly diminishes. That's what we see practically. We need to ensure that urinary retention patients, those on catheter, should be prioritized. We need to make sure that patients on indwelling catheter should have treatment within the first 3 months time. That is the target now. As of now, patients are waiting in some places even up to 12 months for the appropriate treatment. And patients with catheter should be given a complete treatment plan within the 6 weeks time. Catheter is a very, very painful thing. Sometimes it is as bad or even worse than the actual urinary symptoms. But catheter is the only way the patient's kidneys can function and the renal function can be maintained. The incidence of catheter associated infections are ranging up to 10%. Apart from that, there are various other problems like urine leak, hematuria, urgency, pain around the penis, painful erections, or erection is impossible. They will lose the sexual life in those catheter period and catheter cystitis. So we need to provide high quality information to the patients. There is no point in, for example, I'm writing a patient decision aid and then somebody in New Cross doing the same work, somebody in London doing the same work. The GRIFT integrates everything so that the patients can be given a high quality decision aid in a single area. That's why the GRIFT Academy comes into play. We can review the portfolio of the patient information offered for both the LUTS and the surgical options and ensure the patient decision aids are available to facilitate both in the GP surgery and also in the one-stop LUTS clinics. Now, the decision aids can be as complex like this, or it could be like flow charts. So I'm not going to go through that, but if you see, this single page gives the main crux of all the 3 main medications available for the benign prostate hypertrophy. Say alpha blockers, 5-alpha reductase inhibitors, and phosphodiesterase inhibitors. How it works, benefits, disadvantages, and examples of the medications. If the patient decision aid has this particular table, patient can go through that in their free time and they will decide why they were given a dual medication, why they were given only a single medication. If the medication fails, what is the next option available? They can easily understand it. A single page of table or column will give all the information to the patients. This is the main advantage of a robust patient decision aid. And even though this is a busy slide, you can see that there are various treatment options available, which is NICE approved for prostate, the gold standard TURP, laser surgeries of holmium enucleation, urolift, water vapor treatment, and prostatic artery embolization. Apart from this, there are few other treatments like iTind and aquablation, which were not completely accepted or approved by NICE guidelines yet. So this single tabular column gives the mechanism, how it works, what is the need for the catheter, is there any side of infections or incontinence or erectile dysfunction problems, and what is the success rate in 5 years and 10 years time. So these kind of eye-catching single page will make the job of the doctor very easy to discuss the treatment options, and also patients can take this away and make a meaningful decision, and there is no what can I say, like a blind spot for the patient. They know everything on what is happening. So the aim is to offer a comprehensive range of treatment options, develop collaboration between the trust. For example, if I'm working in Sandwell in West Birmingham NHS Trust, I can't get trained in all the treatment modalities. So here, if you see, we are all doing TURP from the training days. From Sandwell point of view, we are starting the holmium laser enucleation service. We have well established Eurolift service. In fact, I'm proud to say that we are one of the leading service providers in UK, if not in the whole Europe. Resume water vapor service, we don't have it in-house, but our neighboring trust, for example, Russell Salt, Dudley, have got that equipments available. So there is a good cooperation within us, so I can go there and do some resume surgeries in case if the patients are interested in it. Prostatic artery embolization is offered by the intervention radiologist. It's available in most of the trust areas. So the collaboration between the trust makes the treatment availability into a wide array of areas and a quick reaching of the patient's treatment. We need to ensure that the bladder outlet operation technologies are available in all the trust, and we need to review the arrangements to make sure that it is appropriately updated. As we discussed, these are all the nice approved methods which we discussed with the help of that chart. And maximizing the day surgery and improved recovering pathways. This is something which we are trying to push ourselves into the limits and push ourselves to see whether we can discharge the patient as a day care, or we can even move the patient surgery into an outpatient setting. So we have developed a fantastic daycare surgeries. As you all know, Birmingham Treatment Center, which is a part of City Hospital. In that, I'm going to show some pictures on how our daycare surgery works. And I'm quite proud to say that we have even pushed the Eurolift surgery into an outpatient settings, where patients can be operated in an outpatient settings, which relieves the pressure on the anesthetic based daycare surgery units or the inpatient units. And British Association of Day Surgeons, they have done a lot of work in it, and this is one of the national day surgery delivery pack, which gives a lot of good inputs on how a daycare surgery should work. Whatever the packs which I am discussing here, like for example, National Day Surgery Delivery Pack or GRIF guidelines for male LUTS, I'm quite happy to share those PDF files, and so please keep in touch with the organizing team, and we will be sending the PDF files for you to refer. So this optimizes both follow-up, and also we are able to keep an audit on how we are performing. So the follow-up arrangements are made. There is no need for the patients to have follow-up in the tertiary care. Even if it is needed, it can be done as a telephone clinic follow-up, and the GPs can make equal taking part in the follow-up. And we are keeping a close eye to make sure that the protocols are maintained and audit trail is maintained. This is the GRIFT guidelines on urology outpatient transformation, where previously if there is an outpatient means, for example, I'm doing a clinic of say 20 patients and I can get patients on anything. It could be a woman with a urinary leak, it could be a patient with a renal lump, it could be a patient with a testicular lump, it could be a patient with blood in the urine, it could be a patient with say urinary symptoms. But now this outpatient transformation pack gives us the option to create a dedicated LUTS clinics, so that in that clinic, whatever 10 patients or 15 patients, my mind is so tuned to discuss only the urinary symptoms, evaluation of it, and various treatment options. This not only makes the job of the surgeon easier because they don't have to think so many things within that single clinic, it also improves the quality, and it helps in training our daycare urology nurses. The nurses who are accompanying us, we have a dedicated lower urinary tract nurses. We have 3 nurses in training, and the training nurses, when they accompany the LUTS clinic maybe for 6 months or even for 3 months, they are so well versed and they are empowered because of this quite straightforward protocols and decision aiding packs, so they can take part in running the clinics parallelly. And so we are indirectly developing a workforce which has special skills in bladder outlet obstruction, and patients are managed under the care of consultants who have special interest in this, not as a general specialist. And we are able to train the nurses in this pathway. So in this particular GRIFT guidelines and in this particular transforming the pathways and making sure the patients are getting the care in one place. There are various other publications also available. As I said, all these publications are available online, but I'm quite happy to supply for those who are interested to learn. So as we discussed, the NICE guidelines are pretty outdated and it's a time to review them. It's 2010, but GRIFT has done a good job of replacing the NICE guidelines at least. And we have the publications on management of LUTS in BMJ, which is again a quite indexed journal, and there are various other articles available for us to help. Apart from this, if you go outside the box and think into the other continents, we have good evidences from both European Urology and American Urology Association giving us the guidelines on this. So we have a delivery checklist. Even though it's a busy slide, it's not something I'm going to go through one by one, but we have a clear checklist on what the patient needs to be done, what the GP can do the best in their GP surgery area. When the patient receives in a tertiary care, what we can do, how we can integrate within our urology area network, how we can prioritize the patients with severe symptoms and those on catheters. So these key actions, if we follow, that itself transform the care, and we have an audit trail to keep an eye on this. So this is the first half of the discussion, predominantly on what is GRIFT, and you may come across the term GRIFT in various other specialties also. It is quite popular in gynecology, ophthalmology, orthopedics, etc. But in urology, it has got a heavy presence, especially in male LUTS. I'm quite happy to discuss any questions now, and then if there are no further questions, I will take you through the one-stop LUTS clinics, what GP can do to improve the service.
Does anyone have any questions? Any hands or anything in the chat? I had a question, Ananda. You talked a little bit about PIFU, which is patient-initiated follow-up.
Yeah.
And I know that's something that all the clinical networks are working on. I'm not sure if GPs are entirely aware of what that is and how it works. So could you just explain a little bit about what that is?
Yeah, thank you, Adela. It's a very, very important question, and it's quite an evolving concept. So I can bring in something like an imaginary patient, like for example, a very apprehensive patient who is having, let us take for example the disease which we are discussing today, having a male LUTS due to benign prostatic hypertrophy. Let us assume the patient was already started on the medications and lifestyle changes by the GP. So we are discussing a gold standard GP setting and gold standard tertiary center referral. A patient is not comfortable with the improvement, and then patient referred back to the tertiary center. So we are seeing the patient in our dedicated 5-star one-stop LUTS clinic. As I said, the advantage of one-stop LUTS clinic is we can review the medications, we can quantify the symptoms, and we can do flexible cystoscopy or scans to measure the volume, everything. And we come to a decision that in spite of GP is quite proactive in giving the lifestyle changes and medications, patient symptoms is not improving. By the time patient traveled from GP to us, it may be easily 6 weeks, if not maybe even 3 months or 4 months. So we know that we have given enough time for the medications to act. And I do all the investigations, and patient prostate size is less than 80 cc, quite suitable, say for example, into a urolift procedure. So patient is having the urolift procedure in the same one-stop LUTS clinic as an outpatient. Procedure goes very well. I'm able to see visually a nice, fully open prostatic cavity. No need for any catheter. Patient goes home on the same day. Now, as of now, what we are doing is I tend to call the patient in 3 months' time to see how they are doing well with the procedure. And that part can be taken over by the urology nurses. At that point, only 2 things can happen. Patient may say, doctor, fantastic job, I'm over the moon, I'm passing urine comfortable, there is no problem, I am pain-free and no symptoms. So all those patients will be referred back to the GP. Again, they are referred back to the GP for namesake, and GPs are not going to see them. But there will be always a small group of patients where, doctor, I feel quite good, I'm very happy, I'm able to sleep well, but I think my urine should be much more brilliant than what is happening. So I don't think you need to do anything further immediately, but I wish I should be able to see you again or reach you again if there is a question or if there is something happening not in the way we wish to happen. These kind of patients unfortunately form a very big basket, not just in the male LUTS, in female urology, in pediatric urology, in stones where we treat the stones. But if there is a small stone remaining, patient may say, oh doctor, you are going to refer back to me to the GP, but I still have this 4 millimeter stone in my left kidney. I don't know when it's going to give me the problem. I presented due to the stone with so much of agonizing symptom. You did a wonderful job of removing the stone, but please don't refer me back to the GP. Truthfully, if you go back, say 20 years back with my historical seniors, they've got hundreds and hundreds of patients of this category where patients are doing fine but will be seen every 12 months just because it can happen. Something may fall apart. So these are the group of patients where the patient initiated follow-up is a very big empowering tool. So the patient initiated follow-up, it's a kind of a pack which has all the details, what they need to do, what they are expected in the improvement, what they need to do in case if they have to contact a tertiary care person, when they have to contact a primary care person. And tertiary care means again we have dedicated male LUTS nurses, so they are quite happy to handle the calls. So patients are actually in essence discharged back to GP's care, but if something happens, the patient doesn't have to knock the doors of the GP surgery and make that service which is already quite pressurized into a overburdened system. Patients can call the tertiary center directly and we are happy to see them. So it's a very, very culture changing thinking, I will say, because previously there was like a clear cutoff. GPs will see the patient referred to tertiary care, patient will travel in the tertiary care for some distance, and then there is a cutoff where patients are discharged to GP and tertiary care has nothing to do. It's like washing the hands. So that kind of fixed boxy culture is completely removed. Even if the patient is discharged, there is a patient initiated follow-up. So patient should be able to reach the tertiary care without disturbing the already overworking GP surgery. In my thinking, this is a very brilliant idea. This will reduce the pressure on the GP surgeries, and number of times these patients really come back to tertiary center is very, very minimal. They are very, very rare. So these patients are having the enough confidence, patients are empowered, but none of the system is getting bogged up with over a need for more appointments or something like that. Thank you for the question. That's a very important evolving area.
Thanks, Nanda. That's really helpful. And just for clarity, how long are patients put on that pathway for? Does it have a time limit?
Yeah, there should be a time limit because as you correctly I can feel what you are thinking, because we always think that at one point the tertiary care should give the patient completely to the primary care. So it all depends upon the individual problem. Say for example, if the patient has got like a 5 millimeter stone in the kidney inside the calyx, which can stay there for lifelong. So those kind of patients, we are quite happy to keep the patient initiated follow-up even for 5 years, if not 10 years, because number one, if the stone moves down, the patient definitely needs a tertiary care involvement. No way GP can treat acute ureteric colic. Number two, the chances of patient coming back to tertiary care is also quite low. So the role of the primary care in that setup is very, very low. So it's better to keep the patient initiated follow-up as long as possible. But at the same time, let us take, for example, the male LUTS, which we are discussing. Patient had a surgery, all the medication stopped. The patient initiated follow-up can be kept maybe for 6 months, if not for a year. Because after 1 year, say 3 years time, if there is a problem, patient can go back to the GP and GP can restart the patient from like an index patient. Lifestyle changes, cutting down the caffeinated drinks, making sure there is no constipation, making sure the hydration is done well, alpha blockers, 5-alpha reductase inhibitors. So GP has a big role to play. So those patients, we can keep the patient initiated follow-up maybe for 1 year. After then, the primary care can take care if needed. But properly surgery done patient, appropriate selection of surgery for appropriate patients, the patient should not bounce back. It should be a lifelong treatment. But we know we have got patients outweigh living quite long, so the prostate can grow back. So the GPs will be seeing them after 1 year, I will say. It all individually designed to the specific diseases.
Thank you. That's really useful to know. And just one last question about PIFU. When a patient is given that information on who to contact in secondary care or tertiary care, is a copy of that sent to the GP?
Yes, should be.
Because I'm just envisaging sometimes patients may come back. GP may not necessarily be aware of this PIFU pathway, but actually if there's a copy of that, it just makes life easier. Or if they're on this pathway for 5 years and they turn up 3 years later, and they may not be aware of it. So are letters sent with all that information onto the GP?
Absolutely. Yeah. I mean, the whole purpose of these kind of webinars are to empower the GP to know that these are the things happening in the tertiary care. These are the things which you may have to be aware of. So the GP should know about this patient-initiated follow-up as a whole, not just urology specific, about all the specialties also. But any communication to the patient, we usually copy the letter to the GP. That's our usual practice. So obviously, if a patient
can we just ask everyone to stay on mute, please? There's some background noise. Thank you.
We're changing your tax, the new tax.
Okay.
But I've got a clinic running.
Can everyone go on mute, please?
Yeah, this afternoon.
Thank you.
Okay. So when the patient initially got finally discharged with this patient-initiated follow-up, when the patient needs to call the tertiary care or secondary care, 1, 2, 3, 4, all the letters will be automatically copied to the GP. So for example, in SWBH, our template itself, like all the letters are addressed to the patient with copy to the GP. So addressing to the patient makes the patients a bit more, what can I say, taking care of their own health rather than the previous old methods like 10 years back. We always do letter to the GP. Thank you for referring this patient. I've seen this Mr. X. He has this problem. I've done this test. I'm going to give this medication, or can you prescribe this medication? Now the whole thing is changed. So everything is patient oriented. Thank you for coming to this clinic. I've seen you. You have this problem XYZ and you're started on this tablet. Even if a tertiary care can't give the prescription, please take this letter to your GP to get the prescription. So we are giving the onus of the patient's care to the patients themselves, and all those letters will be copied to the GP. So in case if the patient has some problem in reaching, GP know what to do. Absolutely, GP should be aware of the individual patients. All the letters will be copied along with the pack, which is the patient initiated follow-up pack.
That's great, thank you. Any other questions on what's been presented so far? Got a hand from Jagdeep Sangha.
Yeah, hi. I'm Jag. I'm actually a pharmaceutical advisor and a pharmacist practitioner in a general practice. Just to understand a bit of the background to this work, I mean, I remember in the past being part of 100-day NHS England challenges in urology. Are we saying that some of the referrals that are going into urology services and urologists could be initially managed in primary care? So I suppose what my question with this piece of work, and obviously the webinar, there's obviously a strategy behind this and a plan with the pathway redesign here. Are we saying that actually some of the referrals that come into secondary care could have been managed in primary care in the first place? So are you seeing things which you think should have been managed in primary care? Is this the background to this piece of work? And apologies, I didn't start at the start to understand where this all came from. Is that what we're obviously trying to develop, this new pathway?
Okay, first of all, Jag, this is not a new pathway. If you go back, especially the question which you have asked, it's absolutely not a new one. If you'd go back to NICE guidelines in 2010, so which is like almost 12 years before, there are guidelines for the GPs to start the patient on, say, lifestyle changes and alpha blockers, 5-alpha reductase inhibitors in the community itself. But somehow that training or that kind of guidelines were not properly distilled into the GP training, and GPs are always trying to refer male LUTS patients back to the tertiary care, even without even basic quantifying like IPS scoring, etc. So it is not something like a hidden protocol to make sure that the GPs are doing it. I'm just using this webinar as a tool to see that GPs who are quite interested in these kind of urological conditions, they can do the IPSS scoring, they can do a bladder scan, which is a very simple thing to know whether the patients are emptying the bladder or not. They can start the medications. It's not something which they are doing outside the remit. It's a fact which is not fully followed in various centers. I'm just trying to reiterate that. But every GP may be working at a different level. For example, I can even name few GPs. Like for example, I got a very good friend and also a GP trainee previously with me, Dr. Mavi Balraj is very good. He has done almost everything in urology what a urology trainee should do. So I'm very sure in his practice he will be more than happy to start all these medications, and there is no need for the tertiary center referral to be made. And once the medications fails, yes, then the patient is heading towards the surgical indications, then we need to jump in. Yes, I'm sorry, you may be having more work now.
No. I mean, for me, I'm absolutely with this. I mean, I've worked in the past because what primary care needed, we had these problems 6, 7 years, 8 years ago. And what primary care needs is a clear pathway
Correct.
for not just GPs, but other practitioners and non-medical prescribers on how we manage these patients. Because even in the practice where I work, I manage these type of patients. And in the past, in certainly Dudley CCG, I worked with a GP with special interest and the urologist, Mr. Chakravarti, who I think is in Wolverhampton now, where we actually created a male and female LUTS pathway. And I was involved in that guidance, and we brought that out in primary care to our Dudley doctors. And I think what would be helpful in primary care is that we need probably a system-wide guideline to try and almost drive the education and training in a similar way some of the pickles for respiratory cardiology, diabetes are doing. And obviously that then can be managed more in primary care. And I would welcome something similar from a urological perspective for male and female LUTS.
Yep.
Thanks a lot. Thank you.
This is one of my area of interest, and I'm very happy to coordinate with the various people, whether it's a community nurse or GP surgeries or pharmacist like yourself. We are here to help you, to empower you and handle as many of patients in their own place, and they need to be referred to tertiary care only if the initial stages fails.
Thanks for that, Jagdeep. Any other questions? I think we can probably move on to the next bit.
Okay, so you all can see the second set of slides on one-stop male LUTS clinic.
Yeah, we can see those.
Yeah, so I will just go through on why we set up, how we set up, how it works now. And as I said, we are still in very early stages, but this GP meeting will enable us to have some referrals specifically addressed for that, which will help the triaging becoming easy, etc. So let's see what's happening in Birmingham Treatment Center. For this set of talk, I need to have some disclosures. I am a proctor and I do a lot of speech for the companies like Teleflex, Rocamed, Olympus and Boston Scientific. And so this is my disclosure. So why there is a need for one-stop LUTS clinic for male LUTS? So as of now, there is a long wait. If the GP is referring a patient for male LUTS, that referral will be mixed among the hundreds, if not thousands of referrals. So patients will be waiting for the general clinic for urology. So there is a long wait. There is absence of robust triaging. That's the best word, rather than telling that there is no way we can triage it, because just triaging hundreds and hundreds of referrals itself will require a couple of employees actually. And the patients were seen by non-specialists. So all the specialists, for example, I am a specialist, urologist with special interest in male LUTS and stones. But in my clinic, sometimes I come across a woman with urine leak. Sometimes I come across a patient with an upper tract kidney cancer. So we tend to see a lot of areas which are slightly outside our remit. The reason why we are seeing is to make sure the patients are seen by the tertiary care quickly, and then based upon the need, I will refer the patient to my colleagues who have the specific special interest. By having a one-stop LUTS clinics, if the GPs can triage and send to us a labeled triage, then we can funnel those patients into this dedicated one-stop LUTS clinics. That makes the job of specialists like me quite easy. And this also reduces multiple visits for the patient. So the one-stop LUTS clinics, I'm going to show you some pictures. It works in a single place where patient have access to the scoring systems, scans, flexible cystoscopies, flow rate. So patient doesn't have to come for 2-3 visits. Even one visit, if the patient fails to attend, then we don't know whether the patient really wants the treatment. Lot of trust. If there is one failure, they will DNA and send the patient back to the GP. And the patient will reach the GP in another 2 weeks time, and patient needs to be referred back again. But having everything in one place, multiple visits are curtailed, DNA is absolutely removed, and we don't have the specialist nurse in the pathway, say 5 years back, 10 years back. But as I said, now we have the specialist nurses who are quite interested to do some specific work for the male LUTS. That also gives them a kind of a job satisfaction that they are doing a quite of a niche work rather than doing the general work day in and day out. So why do you need this one-stop clinic? It's a protocol-based clinic. And I'm going to discuss the male LUTS one-stop clinic in this presentation. Similarly, the one-stop clinic could be for like an increased PSA or for testicular conditions or inguinoscrotal clinic, something like that. And as we know, the male LUTS has become a quite developed subspecialty with so many surgical options, etc. And this becomes a very nice place to train the trainees and also the specialist nurses. It helps us to construct a strong fellowship program. So I had a fellowship in endourology in 2013 before joining as a consultant. So my fellowship is on endourology, which is a broad one. So anything endourological, like for example, stones, laparoscopies or robotic surgeries or endoluminal surgeries, everything comes under endourology. But as I became a consultant, slowly I got specialized into this BPH and stones. So it is very nice to create a fellowship into a much more diversified titles. And patient gets complete outcome in a single visit. He may be spending more time, but in single visit, patient goes home with a complete patient decision aid, which clearly says, this is what you have, this is your score, this is your prostate size, the options are 1, 2, 3, you have opted for 2, let us give you a call in 6 weeks time and take it forward. And there is a big backup from both BOWS and GRIFT recommendations, as we have seen already. So this is the model for the one-stop LUTS clinic. So when the GP is referred, after appropriate initial management, as I said, including medications, including lifestyle changes, the referral needs to be triaged. At this point, if the GPs can refer with a title for one-stop LUTS clinic in bold, underlined, etc., then the triage becomes more easy. So patients will end up in the correct clinic. And we will send the patient a letter or email confirming their appointment. We will send the information leaflet on the one-stop clinic, a bladder diary and all the questionnaires which needs to be filled. So when the patient comes to the clinic, already we got the questionnaire, everything pre-filled and in place. In the clinic, we can do like a urine test, flexible cystoscopy, uroflowmetry, only those which are needed. And then after all these which were done by the specialist nurses, patients will be seen by the urology consultant. And when you are seeing the consultant, patient can be discharged back if the symptoms are manageable, or the GP has done a wonderful job of starting the medication already. Patients can end up in surgery if the medicines were not working and adequate treatment period were given. And patients can be referred to the LUTS clinic nurses, where nurses can keep an eye on them maybe for another one more visit. And some patients may require some specialized test for further management. So this is our Sandwell Hospital's one-stop LUTS clinic leaflet, and Mr. Khan, one of my colleagues, has done a lot of work in this. We are preparing this leaflet with appropriate importance to make sure that it is accessible for those who are having like a visual impairment, and it should be reachable for the patients with any handicap also. So we are taking a lot of time, and maybe in the future we should be able to make the same leaflet in various languages, or at least into predominant language like Urdu or Punjabi, with which we live in Birmingham. And when the patient has got the complete workup done, then the patients can be divided into the surgical options where minimally invasive treatment protecting the ejaculation, and as we discussed, urolift is one of the leading procedure in that aspect along with the resume. And there are non-ejaculatory sparing surgeries like bladder neck incision, green light lasers and holmium lasers for larger prostates. Some patients unfortunately may not be fit for anything and they may end up in catheter for long term, which is not a bad option if the patient is quite crippled, 90-year-old who is happy with the catheter, and there are surgical options available to make them catheter free also. We have done a lot of work in this for the past few years, and we have made a lot of poster publications. For example, this is the poster we published in British Association of Day Surgery, happened in Nottingham, and we have published the lessons learned by doing the prostatic urethral lift as a daycare surgery. But now from the daycare surgery, we are moving to an outpatient setup. And we have published on role of specialist nurses in urolift daycare pathway. I'm not going through this in detail because these are all the things which is not very much needed from the GP point of view. I'm just trying to tailor my talk to the audience. And because of all this hard work, our Sandwell Hospital is recognized as a Urolift Center for Excellence, and it was awarded by the British Association of Urological Surgeons early this year in the month of June. It's quite a proud moment. And now I'm going to show you how our one-stop LUTS clinic works. Most of you may know Birmingham Treatment Center. So this is our center, and purposefully this picture is included to show you that there are enough parking spaces, because these are the patients who are not supposed to come and stay there for overnight or for many nights, etc. This whole Birmingham Treatment Center is supposed to be a daycare unit, opening at 7 o'clock in the morning and shutting down at 8 if not 9 p.m. in the night. So if you come after 10 o'clock, the whole building will be absolutely quiet. That's how we are supposed to work. There is no need for any overnight stay. Patients should go home whatever happens within the day, and urology has inpatient service in Sandwell. If there is a need, we will transfer them to Sandwell. And after having a short parking, patients will come through this revolving door. They will be greeted by the reception team who are handling all the daycare units, including gynecology, ENT, colonoscope, gastroenterologist, everything. And they will be guided through this escalator where they will end up having this urology unit area. As you can see, it's a quite spacious area with a good amount of water facility, etc. So that the patients can, because all these patients have to have access to the water, they need to drink water, so that the tests were done quickly and we can finish a good amount of 10 patients within that half a day span. So then they will enter through the double doors here, and once they enter, there will be a urology specific reception area where the patients will be greeted and their questionnaires will be collected. We have series of rooms where, for example, one room has uroflowmetry, one room has prostate flexible cystoscopy, one room has an ultrasound to measure the prostate. So patient slowly goes through the pathway as needed, and finally will end up in this room. This is the conjoint room, I will say. There is a smaller room where the urology LUTS specialist nurse will sit with the patient, and a bigger room where we can do the procedures directly there. So this is our procedure area. We have access to the computers to record the procedure. This is our dedicated couch, a very simple couch, but we can do wonders with that. We can do prostate biopsies. We have access to the washing area, and these kind of investments are very, very important. So outpatient area with an appropriate couch with leg stirrups is not existent in 95% of the outpatient areas, 95% of the places. So we are living in 2022. This is the time to invest correct equipments in correct places so that the patients are treated more in an ambulatory care rather than taking them to the theater environment. And there is always another room available where the urology nurses can learn from what we are doing, and in future they will be empowered to run these clinics quite independently, while we can do a much more, maybe a taxing job. And so what I'm expecting from the GPs to help this one-stop LUTS clinic to flourish further: please, if there is a patient who has only urinary symptoms, refer them, marking it as for one-stop LUTS clinic. This will really encourage the trust to adopt this technique. For example, if this referral goes to another trust where there is no one-stop LUTS clinic, they will think the GPs are so fond of referring this patient to one-stop LUTS clinic. We haven't got this established. Why can't we learn from our neighboring trust? And that's why this urology area network comes into play. So we all can learn from each other. That will encourage other trusts to adopt this shorter pathway, better patient-oriented pathways. And it's easy to triage. A non-medical person, a secretarial person can triage the patient to the appropriate clinic. And please try to prescribe the alpha blockers, alpha reductase inhibitors. They are very simple tablet. If I'm correct, they are much more simpler than the complex antihypertensives or diabetic medications which you handle day in and day out. And once you prescribe a medications, please refer them and see them in 6 weeks time. Not necessary into face-to-face. You can even ring them, and if they are fine, you are protecting a patient from unnecessarily entering into a tertiary care, which relieves a lot of pressure, so that the pressure can be given to more appropriate cancer patient or patients with catheter, etc. And this will really make the patients to develop into a GP with a male LUTS specialty. Already we have good number of GPs, as I mentioned, who are interested in urology, but they can further improve into much more subspecialization. Thank you. Any questions in that?
Any questions? So I've got another question if no one else has. So regarding this one-stop LUTS clinic, just to clarify, it's only currently in your area. Is that right?
I mean, a lot of trusts were parallelly working on that. So I'm not very sure that if anybody in our local area has got that set up. But to my knowledge, no. But I may be wrong. And even for us, we are started, and our nurses were just finishing the courses. The nurses have to finish a lot of things, like for example prescription course, and they have few targets to do. Kiel University, our local university, has got a wonderful program separately for the physician associates and separately for the nurses who are interested to become a urology specific nurses. And it's quite a very cumbersome program. I'm a faculty in that. That's why they are almost prepared to the level of like a fourth year or fifth year urology training. So it's a time consuming game, but we are getting there. As I said, one of my colleague, Mr. Khan, has done a lot of work in that.
Thank you for that. You also mentioned about GPs with specialist interests, and I was just wondering how much work has been done on that aspect of things.
Yeah, regarding that, the only way, for example, if you ask me, I can do is we are getting quite regularly GPs who are posted in urology, sometimes even for 6 months, and so we will try to train them or convince them about the nicheness of this specialty. And any GPs who are posted with me, they are quite independent in doing flexible cystoscopies, in taking some prostate biopsies, running the clinics, and doing some ward rounds and making some decisions as equivalent to maybe like a year one consultant, I will say. But once they finish the GP surgery training and once they start their actual GP surgery, the actual life, then they are got bounded by various specialty interest and patient groups, so they have lose their color. So it's very important for them to stay that I will stay as a urology specialized GP. And so if the GP surgery has like 6 GPs or 8 GPs, they should maintain their urology specialization, tell other GPs to refer the urology patients to them. Of course, they can't keep themselves immune from other type of specialties, but that will really help them. And we are here to run these kind of GP focused sessions so that they are getting updated accordingly. I'm sure the NICE guidelines will come out with something in next 2 years time, so I may be presenting that on the differences between the 2010 guidelines and the new guidelines. And so the help is here to make sure that the CME, the continuous medical education, is maintained and they are empowered to work as par with the consultants. And urology consultants, being the surgeons, they are left out only with the surgical aspect of it, while the management of the examination, evaluation, medical management can be done at the GP level itself.
Thanks for that. Got a next question from Emma Tilley. To refer to this clinic, do we just do a dictated letter via Choose and Book?
Yeah, in future, I'm very sure in Choose and Book itself, we should be having something like a Dropbox selection where they can select the one-stop clinic. But as of now, in the letter, if it comes with the for one-stop clinic in the title, that makes a lot of our job easy, because last thing we want is, after making so much of time and effort in making this one-stop clinic setup, we don't want a woman of 40-year-old with urinary incontinence ending up in the clinic. We will still treat them, but the woman won't get the best out of the clinic. We want the men who needs the appropriate attention to be addressed to the correct clinic.
Jagdeep, who asked the question earlier, has kindly shared his guidance that they worked on a few years ago in Dudley CCG. Do we know if there's any work going on regarding pathways in the urology network for primary care? Is there currently any guidance or?
Yeah, this GRIF guidelines itself is giving a good amount of pathway on what to do, on what level the tertiary care should be disturbed, etc. As I said, this pack of the GRIF guidelines, which is released in January 2022, the refiguration of the one-stop clinic or outpatient clinics, all these packs are available freely. I'm sure it's quite difficult for a GP suddenly to access it. So I'm quite happy if they contact the organizers. I will send them 2-3 PDFs, but I've given you all the gist of what they need to know from those packs. And the main thing is the patient decision aid, PDA, and which, even though I have something now, which will become outdated easily in next 3 months time, because there are so much of evolving evidences happening. Even in BPH, couple of techniques were almost in the pipeline of NICE approval. So we need to keep them abreast. And as I said to you, Adele, as many GP oriented focus group meetings, we can maintain a high standard of GP education and pathway explanation, etc.
Thank you. Thanks for that. Any other questions from anyone?
So overall, I will try to summarize when people are thinking about any questions. These GRIFT related pathways are here to stay, and in fact my assumption is, because of this robust GRIFT related pathways, even NICE guidelines may go slow, and there is no real pressure on the NICE guidelines to revise the 2010 guidelines. And for those who are GP trainees, I'm very sure they will be questioned on the GRIFT related pathways, not just in the urology, in all other subspecialties during the exams. And even if they are not questioned on that, if they bring out, that will really give them some brownie points. That's for the GP trainees. And second thing is, it's a single place where you get lot of information. It is known as GRIFT Academy, and if you go to GRIFT Academy, it is nicely divided into ophthalmology, gynecology, urology, so you can click into the specific specialties and get the maximum out of it. And from the urology point, we are always available over the phone. I got number of local GPs who even WhatsApp me if there is a question, and lot of time we are able to treat the patients in the GP surgery rather than referring them to the tertiary care.
Thanks for that. We've got a question from Balraj Mavi. What do you think about the PSA guidance for referral usually? Usually we go by age criteria, but NICE was saying PSA over 4, which is a large cohort.
Yeah, this is quite a debatable one, Balraj, and as of now, we are still using the age-specific criteria because that seems to be more appropriate for the patients. But if we start referring every patient, say for PSA more than 4, then it a bit underserves the young patients. Say for example, young patients like those who are on 40s, we need to be careful even if the PSA is 2.5 or 2.6, because the age-specific cutoff is less. And we will be really populating the clinics with the patients 75 to 80-year-old where PSA 4 is absolutely normal, because for them the PSA should be more than 6.5. So the single cutoff, what NICE is trying to advise, I don't think is a good idea. I don't think it will come into the practice also. And regarding that, even though it is slightly outside the remit of today male LUTS topic, I can give some guidance for the GPs. If you have a patient with increased PSA, please try to do the urine dipstick at least in the GP surgery to make sure there is no infection. There is no point in sending the patient with possible infection and then the PSA is repeated in the tertiary care and becoming normal. Patient will bounce back to the GP surgery. It's an absolute waste of the referral loop. So in tertiary care, especially, I'm very particular in not treating a patient who has just got marginal increase in the PSA. We always try to repeat the PSA, and if the repeat PSA is normal, patient will be referred back to the GP straight away. And most of the GPs are now quite good in digital rectal examination. I've come across a proud moments where GPs are referred to me with patients with abnormal prostate on examination, but the PSA is normal. And when we examine also, the prostate seems to be abnormal and they ended up having the appropriate MRI scans and biopsies and finding a cancer. This is the way the GPs should award. This is, I will say, a gold medal to those GPs who are referring with abnormal prostate feeling, but the PSA is normal. Because once the PSA is normal, it's quite common for a GP to think that, okay, PSA is normal, there is no point in referring. There are a lot of patients in the group, what we call it as low secretors, where PSA may be normal, but the cancer may be there. In fact, they perform quite poorly in the cancer pathway. So as far as the increased PSA is concerned, there's nothing wrong in doing another PSA, but I know doing another PSA will really slow down the pathway. But please at least make sure there is no urine infections. Send a blood sample for EGFR. As of now, you may know we have started straight to test pathway for those who have increased PSA, which means patients who are coming to us will be having an MRI scan even before seeing the consultant. So for the straight to test to have a robustness, we need EGFR to be done at the GP surgery itself. No need to chase the results. If you do the bloods, by the time patient comes to us, we will have the EGFR that helps us to patients to go for MRI. That really shortens the patient's visit. And if the MRI is normal, first time when the patient is seeing the consultant, we can make a decision. Your PSA is high, but your MRI is normal. No need for biopsy. Let's do one more PSA in 3 months' time and then take it forward. While previously, patients presented with increased PSA, seen by the doctor, and then had the MRI, and then seen by the doctor. So the lot of multiple steps can be curtailed. So we are discussing almost similar to the one-stop LUTS clinics, how we can make a one-stop increased PSA clinic. There are some trust in the UK where patients are seen in the morning for increased PSA, having an MRI done by midday and having the biopsy done on the same day, where the whole, say, 2 months pathway is reduced to just 1 day. So that's our aim. Our aim is to reduce the patient's visit and make the visit more productive and useful and outcome based.
Thanks for that. That's really helpful. Balraj says thank you as well. Do we have any other questions or comments? Is there anything else you'd like to add?
Yeah, and I'm quite happy to share my details. I think now with this nhs.net email address, if anybody puts Mr. Dhanashegaran or Ananda Dhanashegaran, they can easily catch me in the email. And I'm very sure organizers wise, if somebody reaches you for any pack or physician decision aid and my slides, I'm quite happy to share the 2 sets of slides. So there is nothing for tertiary care. I wish the information to get into the primary care so that the trainees are getting good amount of education and have kind of an interest to take the urology as the subspecialty. And as happening in the modality group of GP surgeries, we have got parallel clinics where, for example, in our setup, we have the urology nurses sitting with us and gaining the knowledge. In modality, we have the GP sitting along with the urology consultants and doing independent urology clinic. And the day will come, we should be able to move some of our outpatient procedures into the GP itself. So just think a situation where a patient attends into a GP surgery quite closer to his home with urine symptoms, and GP is completely empowered with all the decision making aid and given the lifestyle changes or medications, patient got improved. After 3 years time, say for example, the medications were stopped working and the patient goes back to the GP is able to make a decision that this patient is suitable for urolift. They got, say for example, a prostate ultrasound in house and measure the prostate volume less than 80 cc, suitable for urolift. And a GP who is interested can do the urolift in the GP surgery itself. For example, in my training days, I learned vasectomy only from a GP, because at the time none of my consultant supervising people were well versed in doing vasectomy under local anesthesia. So I went to a GP surgery and learned vasectomy from a GP only. So these kind of procedures, whatever happening in the like a daycare procedure or outpatient procedures, can be taken into the GP surgery, so patients can be treated as locally as possible. Possibly down the line, 5 years time, 10 years time, I may be talking on those topics, but that's a future. That's what we are working into.
Thanks, Ananda. I mean, you mentioned that you trained some GPs who were GPs in training doing urology rotation. I don't know what the situation would be, say, if we have established GPs who are then wanting to, have that specialism. I don't know if there's any formal training program set up as of yet, or is that something the network could look into?
Yeah,
There's enough interest.
That should be absolutely, because for example, this GP trainees rotation into urology is not something happened for 20-30 years back. It's quite recent one. And for example, if there is quite a senior consultant, maybe in 50s, but interested in male LUTS, there should be a place where he should be able to attend the tertiary center. For example, our center, where we have a dedicated one-stop LUTS clinic. We are planning to run this clinic every Monday and Tuesday. So all he needs to do is just attend 2 days so that he can see how the clinic happens. And similarly, presence of robust triaging and appropriate referral, everything makes that particular visiting GP to learn a lot in a small time frame. And there should be good amount of funding available for that particular GP, so that whatever the loss of work by the GP surgery should be balanced by the appropriate funding. End of the day, that's very important. And so the patient can have a good amount of outcome. The GPs are trained and they can even attend outpatient surgery so that they know what's happening. Once they have this exposure, maybe even briefly for say 2 days a week, maybe for 6 weeks, that's more than enough, and they will be talking much better than the consultant, because the patients always wishes to hear from the GP first. The GP becomes the next door neighbor to them, and then the tertiary center consultant comes into play. So if the GP is able to talk almost like a consultant, that's much more penetrable into the patient's lifestyle. Whatever we say, like for example, avoid excess of fluid after 5 p.m. in the evening, switch to decaffeinated drinks, those things, if GPs are able to trial it out, I'm sure the acceptance and the change will be more better.
Great, thank you. Question from Deborah Smith: is there any training opportunities for AMPs to learn digital rectal examinations or to examine a prostate?
Yeah, again, that's another very important thing. And we have got like a dedicated mannequins, where like a small boxes, so they can insert the finger and know about it has got 4 sides, so they know this is the normal prostate, this is the nodular prostate T1, this is the T2 stage, this is the T3 stage. In a single box they can know everything. Again, there should be funding available for them to observe one clinic. So for example, a GP getting specialized into male LUTS requires, I will say, twice a week for maybe 4 weeks, if not 6 weeks, so that everything is covered and ticked off everything. But for simple things like AMP wishes to learn digital rectal examination, and we do thousands of clinic. Even yesterday evening I was doing a clinic from 5 o'clock till 8 o'clock. I was on my own, and I've done maybe 20 digital rectal examination in the clinic. So it's a good opportunity for somebody to accompany us. It's out of hours, 5 o'clock, so
yeah.
It should be. The problem is I'm sure none of the AMP will be happy to just travel and do the clinic on their own time. Those days were gone. So they all want it to be appropriately timetabled and funded, etc. That's the era we are living in. Even the trainees expect that. Nobody wants to stretch, but they want to learn. So it should be appropriately timetabled and funded, etc. So if they come to my clinic, I can examine the patient and I know what's there, and they can examine at the same time. So patient won't feel as if they are having a separate two examinations, and then they can tell what they felt and I can correct them if there is a need. It just needs one clinic for them to learn this technique. And as I said, if somebody wants to have a bigger role, like a specific urology specific physician associate or urology nurses, there are courses available in Kiel University. And again, the GRIFT and the Urology Area Network and our local Black and Trail Alliance integrated service providers, they should be able to fund these kind of courses.
Really helpful, thank you. Especially with we've got increasing AMPs and physician assistants who all need that training as well. So it's really important, and it's great that secondary care's, willing and able to offer that. Deborah's asked, who could we contact to arrange attending a clinic?
They can just email me. I will forward them to my secretaries, or I think we have got our own generic email also from urology secretaries point of view. Just call Sanwell and West Birmingham Hospital and ask for urology secretaries. You can talk to any of the secretaries, and you can quote my name that you have spoken to me, or you can just ask, can we have a timetable of Mr. Dhanasekaran, and I'm very happy for them to walk in. I will just double check whether there is need to be any paperwork or something, because we need to be careful on somebody walking from outside. But with this urology area networks developing, we are trying to reduce the paperwork. Say for example, as I said to you, a different energy source may be available in a different hospital, or a colleague from a different hospital can come to my hospital and get trained in urolift. We are trying to remove the HR related paperwork or honorary contracts and those things. So in essence, the City and Sanwell, Rowley Regis and New Cross Hospital, Walsall Manor Hospital, we can move around. So there is something like a physician passport we are working on. So anybody can walk around and take care of the patient at any time. There is no need for honorary contract, which will be only short living. So if the community nurses also can be brought into the same umbrella, they can just walk in, and it is doable. 100% it's doable, and I'm a very strong proponent and supporter of that. And if we are able to do that, then only we will come across the challenges in it. Say for example, there may be a difficulty in getting an approval from the GP surgery side, something like a manager, or from our side. So we need to then bridge the gaps, and then we can make this as another presentation, so that it will be an eye-opener to other urology area networks, say in Manchester or London or Cambridge. And already our urology area network in Black Country Alliance is quite leading in implementing the GRIFT services and implementing the changes and improving the care of men. And so this will further improve the quality of the work what we are doing.
That's great, thank you, that's really helpful. And Deborah says thank you as well.
I have one question, Mr. Dhanasekaran. So I'm GP trainee. So as you mentioned, the GP can do better in starting the alpha blocker and finasteride and things. Can you give some tips on the medication, basically? Because even though I am a trainee, sometimes I ask for help from my supervisor to start two medication together. I feel there is some hesitancy, and we ask for advice and guidance and things. So could you explain a few tips about medication?
Yeah, definitely, Punita. I think that the main thing is it is considered as a super specialty, and it is considered as a tertiary level thing. That myth or that belief should disappear. That is the first thing. And then these two medications are very, very simple. As we had our pharmacy colleague, they will be more than enough to support some GPs who want to prescribe some tertiary hospital level of medications with that. And the easiest thing is to follow the NICE guidelines. If you see the NICE guidelines, all the NICE guidelines were actually tailored with GPs in the center, and others are only like a spoke wheel pattern. So whatever in the NICE guidelines, it is not for the tertiary care. And as I showed you in that GRIFT pathway also, the 1/3 on the left, 1/3 on the right, they're all for the GPs to do, while the middle 1/3 is for the tertiary center, which is only the surgery part of it. So there are only two groups of medicines. One is alpha blocker, other one is 5-alpha reductase inhibitors. Alpha blockers relaxes the sphincter, relaxes the VUJ, has some side effects like, for example, asthenia, decreases the blood pressure because it works on the alpha blockers head to toe. Tamsulosin is relatively selective. The best selective alpha blocker is sildosin, which is not available in UK. Well tolerated, not much side effects. Mostly patients may come with the query that it's not working, but the chances of patients really succumbed by the side effects is very, very less. I will ask them to take as a last thing before they go to sleep, so that even if they have postural hypertension, the chances of falling is relatively less. The next one is the 5-alpha reductase inhibitors. The commonest is finasteride. Second commonest is dutasteride because of the cost. Again, it's only for the prostates who are larger than 30 cc, if not 40 cc, and if the PSA is more than 1.4. So if it is larger, there is nothing wrong in starting in on 5-alpha reductase inhibitors. Beautiful medications. I've got thousands and thousands of patients who are happy with these medicines, including doctors, and preventing the surgery. So if medications are started at appropriate time, it will result in good quality of time. The problem with the BPH is, if it is not addressed appropriately, the bladder will get the secondary effects. And then once the bladder is getting travaculated, circulated with diverticula, the patients will never get that reversibility of their condition. And there will be always a kind of irreversibility. Once the patient is getting into this irreversible stage of the pathogenesis, then comes where the upper tract damage, renal failure, etc., and patients ending up into a chronic renal failure. Chronic renal failure, or CKD in other words, due to prostate, is an absolutely preventable disease if medications are started appropriately, and if there is no symptom improvement, appropriate surgical intervention, which lies in the tertiary care. And we have got a robust scoring system. I'm very sure IPS scoring system is well explained and taught at the level of the GP training. So do the baseline scoring system. After the medications, do another scoring system. You don't have to ask the patient to come directly. The second visit onwards, it could be a telephone visit. Even in the telephone, you can have the scoring system in front of you and score it and compare it with the previous one, and you will feel as if you are working at much higher level. And then if you refer a patient to this one-stop LUTS clinics, if the medications are failed, then it makes our job into a much higher level, where we can directly do the surgical options with the patients, and at one time patients can walk in, first visit, have a urolift done, and going home in the first visit itself. As of now, patients are waiting easily for 6 months to 12 months in this whole pathway. Starting the medicines, failure of medicines, waiting for urolift, various small investigations, and having the urolift. That takes almost a year. The whole thing can be curtailed to 1 day, and that should be like a platinum service, I will say.
Thank you.
Great summary. Dalvinder Ratra has asked if you can have a recording. I just checked with Nicole, but as far as I'm aware, if you're part of this meeting, you will have access to that recording. And then the plan is that we're going to record these webinars, so other people that couldn't attend can also access them when the Training Hub website is all set up and ready. So that shouldn't be a problem. And are you happy to share your slides with us as well?
Of course, yeah. I will email you, Adela. I'm happy to share, yeah.
Thank you so much for that. Is there any final questions or comments before we finish? I think that's it then for today. So thank you everyone for attending. Nicole's put a feedback form in the chat, and if everyone could fill that out, we can exchange that with attendance certificates. And if there are any future urology topics you'd like covered, please also let us know about that. Yeah, we'll send out hopefully the slides and the attendance certificate. And yeah, that's pretty much it for today. So thanks everyone, and have a good rest of the day.
I will complete it by saying that a lot of reinforcement is needed. So if Adela finds a slot, we will try to do a kind of reinforcement of the same talk, which will address maybe a different set of GPs who didn't manage to join us today. And I'm very sure if there is an option for me to talk the same topic in 6 months' time, there will be at least a handful of new things happening in the meantime. It's such a very rapid changing platform, I will say. And thank you for everyone for joining in the morning.
Thank you.